صباح الخير. أنا اسمي دكتور اسامه صبحي، أستاذ متفرغ أمراض السمع والاتزان بقسم الأنف والأذن والحنجرة. بحب أديكم المحاضرة النهاردة بعنوان Audiologic Evaluation. أول حاجة we have to know what are the symptoms that the patient with ear problem is presenting with. The patient with an ear problem could present with hearing loss, with tinnitus, with vertigo, with pain in the ear, earache, or discharge from the ear, which is called otorrhea. Now, what we do for that patient in the ENT clinic, we have to inspect the patient, do ENT examination, and otoscopy is the most important in the ENT clinic because most, if not all, the otitis externa or external ear problems are diagnosed by just otoscopy. We do not need for any further investigations for a patient with an external ear problem. In addition to that, some of the conditions in the middle ear can be diagnosed by otoscopy. So otoscopy is the most important part in the ENT clinic. Now after that, after we finish the otoscopy, we resort to what's called tuning fork tests. And you have to know 3 tests, but I will not talk about them because they should be covered in your clinical practicum. But namely they are Rene test, Weber test, and the Schwabach test. And by the end of these tests, the ENT physician could reach a provisional diagnosis for the condition. That's the Weber test, and that's the Schwabach test. Now, in many conditions, the diagnosis is not settled in the ENT clinic and the patient needs some further investigations, in which case the patient should be referred for the audiovestibular unit for further investigations. What we do in the patient in the audiovestibular clinic is that we do the following tests: pure tone audiometry, tympanometry, speech audiometry, and evoked response audiometry. And those 4 tests are the main subject of our lecture today. I'm going to talk about each one in detail. The 5th one, which is called electronystagmography, is part of the vestibular evaluation, which is a topic of another lecture. But for this lecture, I will talk about the first 4 tests only. We start by pure tone audiometry. As the name entails, pure tone audiometry, audio means hearing, metry means measurement, and we measure hearing using what's called the pure tone. What's a pure tone? It's a tone at a single frequency. A tone at a single frequency is called the pure tone. The machine we are using in order to test for pure tone audiometry is called the pure tone audiometer, and the doctor, as you can see, is seated in front of the audiometer while the patient is seated inside a sound-treated room. That's the pure tone audiometer enclosed. And the patient is tested for what's called the threshold, and in a moment we will know what's meant by threshold. But we test for threshold in 2 conditions: using an earphone in order to test for air conduction threshold, and using a bone vibrator in order to test for bone conduction threshold. Now we have to know what's meant by threshold. Threshold is the least sound intensity in decibels that a human ear can detect in 50% of trials, below which there is no response to sound. Now 50% of trials means that if I give you this tone 10 times, in 5 times you will say, yes, I think I can hear it, barely can hear it. And in 5 times you say, I don't think I can hear it. So the sound is very faint. Now we test for threshold because threshold varies from frequency to another, from one ear to another, and from one person to another. Threshold is usually tested for in absence of any ambient noise. Thus, the sound-treated rooms are used in pure tone audiometry. I have to put a patient in a sound-treated room in order to prevent the ambient noise from affecting or interfering with our measurements. Now we measure hearing threshold for pure tone sounds at audiometric frequencies. Those audiometric frequencies are frequencies at octave intervals, which means that each frequency is double the preceding one at 250 to 8,000 hertz, which means that I will test for thresholds at 250 hertz, 500, 1000, 2000, 4000, and 8000. As you remember from your physiology, that the human audible range of frequencies range from 20 hertz up to 20,000 hertz. But for clinical purposes only, we test for audiometric thresholds only from 250 to 8,000. And the reason we are testing in much narrower range than the range that God has created us with is that all the languages in the world are inside this narrower range. There is no known language to exist outside this range. So for clinical purposes, we are confining ourselves only to testing between 250 to 8,000 hertz. As I said, we use earphones to test for air conduction thresholds. We use bone vibrator for bone conduction thresholds. Simply what we do is that we give the patient an intensity at a little bit higher intensity, like 60 or 70 decibel, and we ask the patient to give us an indication that he has heard the sound just by raising his hands, pushing a button that will illuminate a light in the pure tone audiometer, or if a child, we train him to put a toy from one place to another each time he hears the tone. By any means, the patient should tell me that he has heard that tone. If he has heard that tone, I go down 10 dB, 10 dB, 10 dB, until he doesn't hear anymore. I raise a little bit the intensity for 5 dB and verify that this level is the threshold, and we mark this threshold in the chart that I'm gonna discuss in a moment. Both air conducted thresholds and bone conducted thresholds are displayed on a graph called the pure tone audiogram. The pure tone audiogram is a chart that represents the relationship between the intensity in decibels on the y-axis, which is the vertical axis, versus the frequency in hertz on the x-axis. Now, before I proceed, I have to make sure that you can discriminate or differentiate between intensity, and the unit of intensity is the decibel, and the frequency, and the unit of frequency is the hertz. Now, if I say the phoneme or the speech sound s, then I say s. What differs here is the intensity, the decibel number, but it's the same phoneme, it's the same frequency content. But if I say s, then I say sh. That's another phoneme, which means that's another totally different frequency components, but the level or the decibel number is the same. So different intensities, different decibel numbers means different levels of the sound, different loudness of the sounds. But different frequency units or different hertz means different speech sounds. It can differentiate one letter from another or one speech sound from another. Now, the pure tone audiometry gives us 4 pieces of information. The first piece of information is that does this patient have normal hearing? And in order to have normal hearing, the patient should have his threshold less than 25 decibel across the mid frequencies, which we call them speech frequencies. We take the average threshold at 500 hertz, 1000 hertz, and 2000 hertz, which means that we add the threshold values in decibel at those 3 frequencies. We divide them by 3 to get the average, and we look for that average. If this average is less than 25 decibel for both ear and bone, this patient has normal hearing. The second piece of information is what's the degree of the loss if the patient has hearing loss. Any patient that has a pure tone average that exceeds 25 decibel is said to have hearing loss. Now we look to the this pure tone average to look where does it lie in the following table. If the pure tone average lies between 26 and 40 decibel, that's a case of mild hearing loss. Between 41 and 55 decibel, that's moderate hearing loss. From 56 to 70 decibel, that's moderately severe hearing loss. From 71 to 90 dB, that's severe hearing loss. 91 up to the limit of testing, that's profound hearing loss. If no response at the limit, then that's a case of total hearing loss. So you look for the pure tone average. Where does it lie in that chart, in this table? You will know what is the degree of hearing loss. Now, what's the type of hearing loss, which is the third piece of information you can get from the pure tone audiometry? Depends on the relationship between air conduction and bone conduction thresholds. That classifies hearing type into 3 types. Either into normal or abnormal. Normal if the pure tone audiometry is less than 25 decibel, as I said. If it exceeds 25 decibel, that's abnormal. Now we look to the relationship between air conduction and bone conduction. For a conductive hearing loss, then we have sensory neural hearing loss, and we have mixed hearing loss, which is conductive plus sensory neural. The fourth piece of information is what's the configuration or the shape of hearing loss. And the shape of hearing loss can give us information about the etiology of the loss. In a moment, we will see different configurations of hearing loss. But first, we have to look for the pure tone audiogram. How does it look like? That's the pure tone audiogram. It's a chart that represents the relationship between intensity in decibel on the y-axis or the vertical axis, and you can see that the coordinate starts, the 0 is on the top, is not in the bottom as you are used with all the coordinates. So the 0 is on the top, 120, which is the maximal intensity that the pure tone audiometer can deliver, is on the bottom. Then that's on the vertical axis. On the x-axis, we have frequency in hertz, as you can see, 250 hertz up to 8,000 hertz. That's the chart which is called the pure tone audiogram. Now, after we have obtained the thresholds of the pure tone audiogram, we put them in their allocated places. For example, if this right ear has an audiometric threshold at 1,000 hertz of 15 dB, we come here opposite the 1000, opposite the 15 decibel, and we put a mark here. If we have a threshold at 2000 hertz of 20 decibel, we come here across the 20 decibel and we put a mark here, and so on. So all these marks represent thresholds for air conduction in the right ear. We do the same thing for bone conduction, and that's the internationally known symbol for air and bone conduction threshold for the right ear. We do the same thing for the left ear. Now, this case, the right ear shows normal hearing. Why normal hearing? Because all the thresholds are above the 25 decibel line, which means that numerically the thresholds are less than 25 decibel. So this is a case of normal hearing in the right ear. Now, if you look to the next slide, you will see that this is the right ear is the case of conductive loss. Why conductive loss? Because there is normal bone conduction and abnormal air conduction. Bone conduction is above the 25 decibel line, air conduction thresholds below the 25 decibel line. Now, why is this for conductive hearing loss? Because where is the pathology in the conductive loss? It is in the external or in the middle ear. So the sound that is transmitted through air conduction will be faced by the pathology, will be prevented by the pathology. The pathology will lead to attenuation of the sound. I have to increase the intensity of the sound very much in order to let this patient hears. So we have hearing loss for air conduction. But for bone conduction, the sound did not pass by the pathology. It escaped from the window. It directly vibrated the skull bones, reached the inner ear fluids, and stimulated the auditory nerve without passing through the external or the middle ear, which means that it has escaped the pathology. That's why bone conduction is normal. That's for the case of conductive loss. Now look for the left ear. You will see that at the high frequencies, forget about the low frequencies, I will talk about them in a moment. For the high frequencies, we have sensory neural hearing loss, which means that the thresholds are below the 25 decibel line for both ear and bone. Why? Because in sensory neural loss, the pathology is in the cochlea, inner ear, or in the auditory nerve. Sound going through air conduction will be faced by the pathology, and sound going by bone conduction will be faced by the same pathology. So that's why the air conduction and bone conduction thresholds are shifted or increased by the same amount. That's a case of sensory neural loss. Now for the right ear in this slide, we have mixed loss. Both bone conduction threshold and air conduction thresholds are below the 25 decibel line. But which is better? Of course, bone conduction is better. Why? Because in mixed loss, we have two pathologies. One pathology in the middle ear, one pathology in the inner ear. Sound going through air conduction will have to struggle with two pathologies. But sound going through bone conduction will be faced by only one pathology, which is the pathology in the inner ear. It has escaped the pathology in the middle ear. And that's why the patient has better bone conduction thresholds than air conduction threshold, although both of them are abnormal. So simply, you look for the relationship between air and bone. If the bone is normal, air abnormal, that's conductive loss. If both air and bone are equal and abnormal, that's sensory neural loss. If both of them are abnormal, but bone is better than air, that is mixed hearing loss. Now, the final and last piece of information you can get from the pure tone audiogram is what is the configuration of hearing loss. As I said, the configuration helps us to predict or know the etiology of the loss. So look at the left ear. Is this normal hearing? Yes, it is normal hearing at all frequencies except at 1000 hertz where there is hearing loss. There is sensory neural hearing loss at 4000 hertz. When we see this condition, I have to ask the patient, have you ever been exposed to very high intensity sound like gun shooting, like if he is a soldier in the military using RPG rockets or firing arms, if he is going to hunting, because this patient has been exposed to very high intensity sound, a sound that exceeds 135 decibel, even for a fraction of a second, he can sustain this sensory neural hearing loss at 4000, and it is a permanent condition. It is a permanent condition. Now look at the left ear. The left ear shows normal hearing at low frequencies, 250, 500, and 1000 hertz, normal thresholds, but it has a sloping thresholds at high frequencies, which means that there is hearing loss at the high frequencies. If you see this condition, you have to think of any of the four most common causes of high frequency sensory neural hearing loss. The first is presbycusis, or hearing loss due to aging. Above the age of 60, all the patients or all the subjects in the community will start to have some degree of hearing loss at 8000 that creeps to lower and lower frequencies as the age advances. By the age of 80, there is nobody with normal hearing. That's called presbyacusis. And that's the most common cause of high frequency sensory neural loss. The second is heredofamilial hearing loss. Heredofamilial hearing loss is commonly occurring at high frequency hearing, at high frequency thresholds. The third is noise-induced hearing loss. Noise-induced hearing loss, those are the workers going to factories and are exposed to moderately high intensities, like 190 decibel, 85 decibel, but the exposure time is very long. They go to the factory 8 hours a day, 6 days a week, for 3 or 4 or 5 years, they start to have this high frequency sensory neural loss. And you have to differentiate it from acoustic trauma that we have seen. Acoustic trauma is a very high intensity for a brief time, but noise-induced hearing loss or occupational hearing loss is exposure to moderately high intensities for a prolonged time. The fourth and last common cause of high-frequency sensory neural loss is ototoxicity. The intake of some medications like aminoglycosides lead to high-frequency sensory neural loss. So to summarize, the 4 most common causes of high-frequency sensory neural loss, we have presbycusis, we have heredofamilial hearing loss, we have noise-induced hearing loss or occupational hearing loss, and we have ototoxicity. Finally, if you look to the left ear, that's the reverse configuration. That's low frequency sensory neural loss. The patient has normal audiometric thresholds at high frequencies, but abnormal or sensory neural loss at low frequencies. And the most common cause for that is Meniere's disease. If this condition is unilateral and the patient does complain from vertigo, then we have diagnosed a case of Meniere's disease. What else? We have sudden sensory neural hearing loss, is usually characterized by low frequency sensory neural loss. What else? Some cases of heredofamilial hearing loss are characterized by low frequency hearing loss. What else? Autoimmune inner ear disease are characterized by low frequency hearing loss. To summarize, we have the 4 most common causes for low frequency sensory neural loss. We have Meniere's disease, we have sudden sensory neural hearing loss, we have heredofamilial hearing loss, and we have the 4th most common is the autoimmune inner ear disease. By this, I have finished the pure tone audiometry. And now I proceed to the second test, which is speech audiometry. Again, as the name entails, speech audiometry. Audio means hearing, metry means measurement, and we are using speech in order to measure hearing. Now you have to know that speech audiometry contains or consists of 2 tests. The first test is to test for speech threshold. Testing by speech threshold in order to get what's called the speech reception threshold. We put the patient inside the sound treated room. We ask him to repeat words after me. I give him some speech materials at 60 decibel. If he can repeat it, I go to 50. Can repeat it, I go to 40, 30, 20. If he cannot repeat it at 20, I go up a little bit to 25. I verify that at 25 he can repeat 50% of the words, then that's his speech threshold. Now why are we doing or testing for speech threshold? Because a speech threshold can confirm the results of the pure tone audiogram. You have to know that speech reception threshold should equal the pure tone average that we have talked about in the pure tone audiometry. If I have a pure tone audiometry of 55 decibel, then I should get speech reception threshold at 55 decibel, for example. Now, what if those speech reception threshold did not equal the pure tone audiometry? This means that there is something wrong with the pure tone audiometry. I have to verify it. I have to repeat it, because in some cases the patient may be a liar. He is faking hearing loss. For any reason, he wants to prove that he has hearing loss for any reason. And in order to detect those patients, we have to do both speech reception threshold and pure tone audiometry in order to see if they are identical or not. If not identical, then we know that the pure tone audiometry is there is something wrong with it. Also in children, in uncooperative patients, in all those patients, you might have a discrepancy between speech reception threshold and pure tone audiometry, and you have to go back and recheck your pure tone audiometry. Put the patient instructions one more time in order to verify that the thresholds are accurate. The second test in the speech audiometry is to test for speech discrimination score. Speech discrimination score. We ask the patient to repeat after me. I say 25 words, and the patient should repeat me those 25 words. If the patient can repeat, for example, 15 words of the 25, this means that his speech discrimination score is 60%. Each word is counted for 4% because there are 25 words, and I have to calculate the percentage of correctly repeated words. The importance of the word discrimination score is that it helps us to localize the site of lesion, which means that it confirms the results of the pure tone audiometry regarding the type of hearing loss. In conductive loss, we have excellent discrimination score, 90 to 100%. In sensory, which means a cochlear loss, we have a score between 70 and 90%. In neural loss, we have scores which are very poor, 0 to 50%. Why? Because in conductive loss, the only problem of the patient is the loudness of the sound. The loudness. If you just increase the loudness, then the patient can repeat all the words correctly, exactly like the normal individual. But for cochlear loss, the problem is different. You know from your physiology that the cochlea is tonotopically organized, which means that the high frequencies are transmitted through the base of the cochlea, through neurons of the base of the cochlea. Low frequencies at the apex of the cochlea near the helicotrema. Mid frequencies are in between. So if you have a lesion that led to complete wiping or death of the hair cells at the high frequencies, this means that this patient cannot listen to high frequency sounds, which means that if you give the patient a word with a high frequency phoneme like s or sh or f or kh, all these high frequency sounds cannot be heard by the patient. Even if you increase the intensity of the sound, he will not be able to hear to them. That's why he will never be able to correctly repeat all the words and get 100% speech discrimination score. In neural loss, the problem is more. The cable that is transmitting the data from the cochlea to the brain is damaged. This cable can transmit some pure tones, but it cannot transmit speech correctly, and that's why the patient might have mild or moderate loss, but his discrimination is very poor. So the word discrimination score can confirm for us the different three types of hearing loss. Finally, the word discrimination score can help us detect who is the patient that is in need of a rehabilitation or restoration of his hearing, either by surgery or by hearing aids. Now I come to the third test, which is tympanometry. Tympanometry, as the word entails, metry means measurement, tympano is measurement of the middle ear. This test is specific for middle ear diseases, and the machine or the instrument we are using in order to test for tympanometry is called impedance meter or tympanometer. As you can see, the patient is seated beside the instrument, and I will not go much into details of the machine or how does it work, because that's outside the scope of this lecture. But I will tell you that this machine or instrument gives us two pieces of information regarding the middle ear function. The first piece of information is what is the compliance of the middle ear. Compliance means how easy the sound is transmitted through the tympano-ossicular chain. And that's the reverse of impedance or resistance. compliance is measured in cubic centimeters, cc. The second parameter that this instrument can give us about the middle ear is what is the pressure inside the middle ear. What is the pressure inside the middle ear? You have to know the normal values for both compliance and pressure. The normal pressure of the middle ear is 0, which is atmospheric pressure. And it ranges from plus 50 to minus 50 decapascal. That's the unit of the pressure. That's the normal pressure. The normal compliance ranges from 0.3 to 1.7 cc. From 0.3 to 1.7 cc. Now, this instrument gives us what's called tympanogram. And tympanogram is a chart that represents the relationship between, on the x-axis, we have pressure and we have 0 atmospheric, which is atmospheric pressure. We have plus 100, plus 200. We have on the other side, from the 0, minus 100, minus 200, down to minus 400 decapascals. That's the pressure on the x-axis. On the y-axis, we have compliance in cubic centimeter. Now, type A tympanogram, which is the first one on the left, top left, we have type A tympanogram. That is the normal tympanogram. Normal for pressure, because we know the pressure occurs at the peak of the curve. That's the solid line here. The peak of the curve is opposite 0, so that's 0 pressure inside the middle ear, which means that it's normal pressure, it's atmospheric pressure. And the compliance, which is the height of the curve, and we can see here that the height of the curve is about 0.7 or 0.8 cc. That's normal, that's inside the range of the normal. So type A tympanogram is normal for compliance and normal for pressure. The second one, which is in the middle panel, top, that's the B tympanogram or flat tympanogram. Tympanogram that does not change compliance with the change of the pressure. It's all the way fixed. Why it is fixed? Because the tympano-ossicular chain is not movable. Why it is not movable? Because there is fluid inside the middle ear. So type B tympanogram is pathognomonic. It's diagnostic for middle ear effusion or secretory otitis media. The third one is type C tympanogram, where there is normal compliance. As you can see here, it's about 0.7 cc compliance, normal compliance, but negative middle ear pressure. Look at the peak of the pressure. It is opposite, about minus 250. That's well below the normal range of minus 50 decapascals. So that's negative middle ear pressure. Why it is negative? Because the Eustachian tube is not functioning well. So that's pathognomonic for Eustachian tubal dysfunction. Type C tympanogram, pathognomonic for Eustachian tubal dysfunction. Look at the bottom panels. We have the one on the left. It's called type AS tympanogram. The pressure is okay, is at 0. Peak pressure occurs at 0, but the compliance is short or stunted. We call it type AS because it's a stunted or short, and that's diagnostic for otosclerosis. The system has very high impedance or very high resistance to the passage of the sounds due to deposition of spongy bone around the footplate of the stapes, preventing it from freely moving. So that's why the resistance is increased, and as I told you, resistance is the opposite of compliance. So as the resistance increased, compliance goes down, and that's why compliance is very short in cases of otosclerosis. Now the last one is the type AD tympanogram. The pressure is okay at minus 50. However, the compliance is very high. Compliance is very high. And this is happening in cases of ossicular disconnection when the ossicles are fractured. And usually that happens after a road traffic accident. In this condition, the compliance is increased because the system has no resistance. The system is disconnected from each other. Ossicles are disconnected. So the compliance is high. Now, you have to know that this condition is associated with hearing loss because the ossicles are fractured, so sound cannot be transmitted efficiently to the inner ear. The patient has conductive hearing loss, but the compliance is increased. So increased compliance doesn't mean that better hearing. Increased compliance means that the system has no resistance. And since there is no resistance, resistance is very low, compliance is very high. Those are the 5 types of tympanograms you have to know. Type A, normal. Type B, for secretive otitis media. Type C, for Eustachian dysfunction. Type AS, for otosclerosis. Type AD, for ossicular disconnection. Also, type AD occurs in another condition which is called atelectatic tympanic membrane, where the tympanic membrane is very thin and hypermobile, leading to increased compliance. By this, I end up the talk about tympanometry, and now I go to the last piece of the lecture today, which is auditory evoked potentials. What are the auditory evoked potentials? They are electrical voltages recorded from the brainstem auditory pathway using electrodes placed on the skull. When we hear, the sound is transmitted from the external to the middle, to the inner ear, to the auditory nerve, then finally it reaches specific stations or points or stops in the brainstem. When the neurons of the brainstem get excited by the sound at those specific stations, they give electrical activity. This electrical activity is embedded inside huge electrical activities in the brain called the EEG. Now, in this specific test, we extract the electrical activity generated by the auditory nuclei from the rest of the electrical activity of the brain. And we are using electrodes that are put on the skull. Now, why we are doing that? Because in many conditions, we cannot get any information about hearing from pure tone audiometry. If you have a child, if you have a newborn, if you need to know the hearing for an infant or a baby that has an age of 1 or 2 hours, for a baby with 1 or 2 days, you will not be able to use the pure tone audiometry, of course. The same thing with a mentally handicapped patient, the same thing with a malingerer or patient, or he is faking hearing loss. You cannot obtain pure tone audiometry. So we resort to these auditory evoked responses. They are also used to measure the condition of the neural input in the neurologic disorders like multiple sclerosis and space occupying lesions. Now, what are those electrical activity? Those electrical activity generated by the brainstem nuclei are composed of 5 different waves. Now, as you can see from this graph, you have on the x-axis, you have time in milliseconds. Millisecond means 1 over 1,000 of a second, 1,000th of a second. On the y-axis, you have microvolt, which is 10 raised to power minus 6, 1 over 1 million of a volt. That's a microvolt. Since they are electrical activity, so they are measured in microvolts. And they are occurring in sequence, one after the other, and that's why the x-axis is the time. So wave 1, we know that wave 1 is generated by the auditory nerve, wave 2 is generated by the auditory nerve also as it enters the brainstem after crossing the cerebellopontine angle. Wave 3 is generated by the cochlear nucleus inside the brainstem. Wave 4 is generated by the superior olivary complex in the pontomedullary junction. Wave 5 is generated by the inferior colliculus in the midbrain. So we know where each wave is generated from. The presence or the recording of these waves means that all the system before the brainstem is okay. So it means that the external, middle, inner ear and auditory nerve are okay. Now we can obtain thresholds using these auditory brainstem responses. And you have to know that auditory brainstem response is the specific test and it's part of the auditory evoked potentials. Now the ABR thresholds that is obtained, how it is obtained, we get a baby, we ask the mother to feed him in order to go for sleep, and we put the electrodes on the scalp and we give him a sound through an earphone, and this sound we start by higher intensity like 80 decibel, and if we can obtain the 5 waves, then we know this baby can listen to 80 decibel. So we go down by 20 decibel, we go to 60, there is a response, we go to 40, there is a response, we go to 20, there is a response, 10 dB, there is no response. So where is our threshold? Threshold is at 20 decibel. 20 decibel, as I said, is normal hearing because the cutoff limit of the normal hearing is 25 decibel. So this is a case of normal hearing as detected by auditory brainstem thresholds. Look at this case. We have the 5 waveforms of the ABR for 100, and we repeat 100 in order to make that the responses are repeatable. At 80 decibel, we have normal, we have responses also. At 60 decibel, we have repeatable responses. At 50, there is nothing. What's the threshold? Threshold is 60 decibel because it's the least intensity that we can get responses at. So threshold is at 60 decibel. That's a case of moderately severe hearing loss. So simply we can detect the threshold of the child by studying the threshold of the ABR waveforms and look at the least intensity that can yield responses or auditory brainstem responses. That is auditory brainstem response. The second application is we can verify the integrity of the brainstem structures. As I told you, the different waves are occurring in sequence. So if you study the time relationship between the different waves, you will know something about the conduction time of the waves. The conduction time gives us information about the intactness or the integrity of the brainstem structures. We study the time relationship between wave 1 and 3, which is called 1 to 3 interpeak interval. We study 3 to 5 interpeak interval, and we have normal values. And also we compare the right ear with the left ear. In this condition, on this slide, there is a normal ABR response, comparable absolute and interpeak latencies. All the waves are occurring at the same time for both the right and left ear. Now if you look to this case, in the left ear, peak and interpeak latencies are normal. They are comparable to the norms that we know. But for the left ear, for the right ear, which is the traces in the bottom, you will see that the wave 1 is okay. It's occurring at the same latencies like the left ear, but wave 3 is very much prolonged or delayed. Why? Because this is a case of acoustic neuroma. It's a tumor in the auditory nerve that has led to prolongation of the interpeak latency. 1 to 3 interpeak latency increase, which is significant for a pathology within the nerve itself. A pathology within the brainstem, like multiple sclerosis, can reflect in prolongation of 3 to 5 interpeak latency. So studying the timing relationship between the different waves can tell us something about a hidden pathology in the central auditory pathway. And that's the second application of the auditory brainstem response. So we have 2 applications: testing for thresholds for difficult to test patients, like babies, like infants, like mentally handicapped, like malingerers. And the second application is testing for the integrity of the central auditory pathway. And thank you.